started?
Oh, okay. This is a weird place, huh? Perfect dress for it, right?
Yeah.
No place to.
So thank you all for coming. I'm sure more people will trickle in as we get started. So I'm going to briefly introduce Dr. Tanner, and then we'll get started with her presentation. So Dr. Nichole Tanner is an assistant professor here at MUSC in the Division of Pulmonary Critical Care with a joint appointment at the Ralph H. Johnson VA Hospital. She completed her internal medicine and pulmonary critical care training at MUSC. She's a lung cancer pulmonologist with expertise in all aspects of lung cancer, including screening, diagnostics, and staging for known or suspected lung cancer and pulmonary nodule management. She was one of 8 national site leads for the National VA Lung Cancer Screening Demonstration Project designed to test implementation of lung cancer screening with the Veterans Health Administration. She's also the co-director for the Lung Cancer Screening Program at MUSC's Hollins Cancer Center, and her research focuses on lung cancer screening, pulmonology nodule management, and device evaluation. Today she'll be speaking on lung cancer disparities and with a focus on screening and treatment. Please welcome Dr. Nichole Tanner.
Thank you so much. All right, so thank you guys for breaking your morning. Hopefully I won't bore you to tears. So it was very kind of you all to invite me to speak about disparities in lung cancer. And so my understanding is that the focus of this year's DREAM seminar is really precision treatment. And so this isn't really necessarily precision treatment at the cellular level, but it is precise about, things that we can look at and future research questions to be asked as lung cancer screening is really in its infancy. So these are my disclosures. I do a number of consulting jobs, I guess, for certain industries, as well as I have a number of research grants, including one from the ACCP, which is the American College of Chest Physicians, which funded a lot of this research. Okay. Oh, so let's skip that. That was my personal outline. All right. So smoking is the principal cause of lung cancer. It's estimated to be responsible for about 85% of all types of this cancer. And so if you look at, smoking is one of the biggest reasons that people develop lung cancer. And so I'm just going to kind of give you the scope of cigarette smoke. And I have Dr. Ben Toll, who's sitting front and center here, who is the co-director of the Hollins Lung Cancer Screening Program. He's a smoking cessation expert. And so, Ben, just feel free to chime in at any point. But I think it's important to understand the scope of cigarettes as it applies to lung cancer, because that's a huge area that we need to research, I think, further. So if you look at the use of cigarettes by health insurance status, and this is taken from some work done in 2014, what you see is that the majority of people that are current smokers are either uninsured or are on Medicaid, so lower socioeconomic status, so a very small proportion with private insurance. And this has implications as we talk about disparities in general and in disparities for lung cancer. If you look by education level of current smokers, the majority of people who smoke have less than a high school degree. So 30% of people surveyed, 19% some college, 24% high school. So if you look here, really the big proportion of people that smoke in the United States, at least by 2014, had a lower education level in general. If you look at smoking behavior based on race and ethnicity, and I'll walk you through this, and this is done, again, in the 2014 group, in adults older than the age of 18, what you see is that there are more black smokers than white smokers. Overall, multiple race people that check the box other, a lot of current cigarette smokers. So, and I have to thank Patricia Rivera at UNC for some of these slides. So the tobacco companies are actually aggressively targeting minorities, and it's probably not news to the people in this room. But if you look back at historically what they've said and what the ads have looked like, if you look at Philip Morris in particular, one of the quotes that came from their organizational stuff is Marlboro would prefer to have, will probably have a very difficult time getting anywhere in the young black market. The odds against is that they're heavy, young blacks have found their thing, and it's menthol in general and cool in particular. And so here you have an advertisement for mentholated cigarettes with a very handsome man thinking about smoking cigarettes, I suppose. Then if you look at R.J. Reynolds, since younger adult blacks overwhelmingly prefer menthol cigarettes, there should be a continued emphasis on Salem within the black market. Salem's already positioned against younger adults. The emphasis on a younger adult black market may be able to provide an alternative to Newport to capitalize on Kohl's decline. And so here you have the Salem ads with, again, a very sultry-looking, beautiful person smoking a cigarette. So they're targeting minorities. And if you look in the Hispanic community, the same has been true. Spanish-speaking consumers are extremely loyal to brands advertised to them, but to win them takes more than simple translation. The newly arrived are less competent in the English language, less knowledgeable about American brands, and less sophisticated in their reactions. So in response to this is back in 1984, in response to that, they put their advertisements here in Spanish, and you have some very happy people that are talking about smoking Newports, and they're looking for brand loyalty. So really, tobacco companies have historically been aggressively targeting minority groups. And then if you look at children minority groups, minority and low-income neighborhoods tend to have more tobacco retailers. Tobacco retailer densities near schools is higher in minority areas. So kids are walking to school by the local 7-Eleven, and you've got Marlboro ads in the window. Higher density of such retailers near schools have been found, not surprisingly, to increase the number of kids that are actually experimenting with cigarette smoke. If you see it, you're going to want to try it. And they offer more discounts and promotions, coupons for a pack of cigarettes or a carton of cigarettes. So really aggressive types of advertising. So that just kind of switches me. So we know what the scope of tobacco use is in the country. We know that it's used higher in minorities, those that are undereducated, less likely to have health insurance. And so let's talk a little bit about the scope of lung cancer, because as I mentioned in the beginning, smoking leads to lung cancer. So there's 1.3 billion smokers globally. 10 million cigarettes are purchased per minute. There are 5 trillion cigarettes that are produced and consumed annually. That just blows my mind. That's a lot of zeros. 1.7 million new lung cancers are diagnosed annually, with 1.4 million deaths. And then the cost, the bottom line, is about $29 billion spent on lung cancer annually. And so if you look just within the United States and worldwide, it's the leading cause of cancer death, more than prostate, colon, and breast combined. And in 2015 in the U.S., there were over 200,000 new cases of lung cancer and over 158,000 deaths, accounting for 27% of all cancer-related deaths. So lung cancer is a big deal. Now, I bring this last point up, and those of you that have seen me speak before have heard me say this. The overall 5-year survivorship is not good in lung cancer. For all comers, it's 17%. But if you break that down by stage 1 being very early, where you can cure it with surgery, the survivorship is 58 to 73%. The unfortunate thing is, up until recently, only 15% present with early stage disease at a time where it's curable. And the reason for that is that you have a tumor and you might not have symptoms for years until you start coughing up blood, and by that time, it's been too late. So if you look at the stage of diagnosis of lung cancer by ethnicity, and this is based on the SEER data from 2001, 2003, I will just point you in this direction. So localized disease means just that. It's right in that spot. It hasn't traveled. So this is early stage. This means spread to lymph nodes. And then distance means metastatic disease, or disease that's spread from the chest to other organs. And so if you look overwhelmingly, there are more whites that are diagnosed at an earlier stage. So less blacks and Hispanics are diagnosed with early stage cancers. More blacks are diagnosed with distant disease. Same thing for Hispanics. And so what we see is that minorities are at a disadvantage at the time of diagnosis. This is before the era of lung cancer screening, and that they present with more advanced disease, at which time they're less likely to be cured. Okay? And so that brings us to this. If you look at the lung cancer deaths per 1,000 persons, and I'm not sure how well that projects back there, but what you'll see is that male blacks versus all races, 73.1 per 1,000 persons. So they're more likely to die from lung cancer than their white counterparts across the board. Females, a little bit less so. They're similar there. But so among blacks with low socioeconomic status, death rates are twice the national average. So then if you look at lung cancer survival by race and gender, what you can see is that white females did the best, followed by black females, which are kind of mimic white males. But then if you look at black males, they're more likely to die from lung cancer. Black males are. And so these are the facts. This is what it shows us, and this shows us areas where we could potentially do some research to try to improve this. And so When you look at the ethnic differences in lung cancer, as I said before, they're more likely to develop and die from lung cancer than persons of other racial or ethnic groups. And the age-adjusted lung cancer incidence rate among black men is approximately 32% higher than for white men, even though their overall exposure to cigarette smoke is lower. And I'll talk about that in a little bit, this idea of the types of cigarettes that are used and how long people smoked, how deeply they inhaled. There's a whole science behind it that kind of tries to explain why blacks who smoke less packs actually present with more disease. And a lot of the thought is the duration, the number of years they smoke is longer, even though they might not be smoking as many packs. They inhale deeper, and they smoke cigarettes with higher tar levels that might play into the pathophysiology of lung cancer. So the lung cancer incidence rate for black women is roughly equal to white women, although they smoke fewer cigarettes. And that's what I'm talking about, fewer cigarettes, but for longer years. So you might have a white woman who smokes a pack a day for 15 years and a black woman that smokes a half a pack a day for 30 years. And then the way they're inhaling is different. The types of tars in the cigarettes that are actively marketed to them are different. And so all of that is up for discussion. And so part of the talk was titled Treatment Disparities, and I really don't have a lot of research on treatment of my own to talk about, but I think it's important to look at the disparities in treatment among races for lung cancer. So just to break it down, stage 1 and stage 2 lung cancers, those are early stage lung cancers. The gold standard is, for those of you that are not oncologists in the room, is surgical resection. So you go to the operating room, you have an increased chance of survival by having surgery. If you have stage 2, you might have postoperative chemotherapy. So that's considered the gold standard. Stage 3 and stage 4 is chemo and radiation for stage 3, and stage 4 is chemo alone. So blacks with stage 1 or stage 2 are less likely to receive the recommended surgery compared to whites. And this is even when you adjust for income and insurance status. And I think that this disparity probably accounts for a lot of the differences in survival rates. And I don't know that I allude to it in any of these slides, but we in conjunction with the folks at the VA in Pennsylvania, Mitch Margolis there, came up with a study that surveyed African Americans looking at their preferences for surgery in lung cancer. And basically there's this I guess it's called an old wives' tale adage that, having surgery exposes the tumor to the air, and that causes it to spread, and so they're less likely to accept surgery for lung cancer. And so that's something that requires a lot of education. I'll tell you, I probably get that question from one of my VA patients once every 2 weeks. So if you cut on me, isn't it going to spread through the air? So then the other treatment disparity really is targeted therapy. And for those of you in this room that do lung cancer, you know that there's this great movement towards targeted therapy for somebody who is mutated. So we now, lung cancer is moving much towards individualized, personalized therapy. So we diagnose someone with stage 4 lung cancer, and we'll do a huge panel of mutations because there might be a pill for that. So we have targeted therapies for driver mutations that are extending life beyond the 4 months that we used to quote someone. So someone comes in with stage 4, we'll say, you have 4 months. We give you chemo. You might live 9 to 12 months. Now we have these targeted therapies that aren't perfect. They still don't cure, but they are extending life to 2 to 3 years longer than initially before. And so they're available and now are the first-line therapy for someone with a newly diagnosed stage 4 lung cancer. But there's really hardly any research on lung cancer disparities based on race and ethnicity in treatment with targeted therapies. And we don't know what the frequencies of actionable mutations are in the black population. There's just not enough. Like I said, we haven't really been doing a lot of tumor testing. We know a lot about the Asian population because a lot of that work is going on in Japan and China, where there's a lot of these incidents of driver mutations. But we just don't know anything in the black population or if they're being offered it as much. And so this is kind of like the new cutting-edge targeted precision medicine therapy for lung cancer. And I think that there's a role for looking at how it's being offered to minorities, et cetera, because it's not cheap. Lastly, palliative care. And so what we know about palliative care in advanced stage lung cancer is that giving someone palliative care or introducing them to hospice early on actually improves the quality of life and prolongs life, surprisingly. But this survey that was done and published in the Annals of Internal Medicine in 1997, I realize that was long ago, but there's not been much work done since then, shows that only 25% of pharmacies in predominantly non-white neighborhoods stocked morphine versus 72% in affluent white neighborhoods. And part of palliative care is pain control, right? So if you've got bone metastasis, you want to be treated with narcotics, but if your pharmacy doesn't carry them, that's a problem. 65% of African Americans and Hispanics do not receive guideline-recommended pain medications for cancers compared to the 50% of non-white minorities. So there's a disparity there as well. So hopefully what I've outlined for you is that there's a disparity in treatment for lung cancer at all stages between minorities and whites, in that minorities are diagnosed at a later stage. They're less likely to get guideline-directed surgeries, or we don't know much about what happens for stage 4 in targeted therapies. And now in palliative care at the end of life, they're not getting the guideline-directed pain medication. So there's a lot of work that can be done, but we can only bite off part of the research questions. So I'm going to talk to you and switch goals and switch gears here and talk about screening and explain to you why I think it's important. So when you do screening for anything, breast, prostate, colon, you want to follow these definitions. So the definition of a good screening test is that it's a systematic examination of asymptomatic people. So you want somebody who's not coughing up blood to detect and treat disease. And the principles are that the disease has to be relatively common. Well, lung cancer is very relatively common. I think I've hopefully proved that to you. The disease must have a high mortality, check. The disease must be less treatable when symptomatic versus when detected early, check. And the benefits of treatment of a small number of diagnosed patients has to outweigh the harms of screening a large number of healthy people. And that's kind of some of the work we're looking at now is, there's a lot of risks and benefits to screening for anything, including lung cancer. But lung cancer meets all of these things. And wouldn't it be great if we could detect it at an earlier stage? Because I told you the majority of patients are presenting with locally advanced or metastatic disease at the time of diagnosis. So if we could shift the stage from 3 and 4 to 1 and 2, wouldn't we be doing a great service? And so the evidence for screening comes from, here's the timeline for how screening has gone down. So when I say screening is in its infancy, it's all relative in medicine, right? So 2011 is when the landmark trial came out. In 2015 of March is when CMS, or Medicare and Medicaid, approved lung cancer screening with low-dose CT scan. And that was 2 years after the U.S. Preventative Services Task Force gave a grade B recommendation. And so this is kind of the age groups, and this is the, quote, high-risk population, current or former smokers, 30-pack years, quit within the past 15 years. And again, this is the really overarching thing, is that they have to be asymptomatic and not have any disease that could preclude them from going to the gold standard curative surgery. And so I'll get questions like, oh, well, can't they go for radiation? Yeah, that's not who we're trying to screen. That's not who was screened in the trial, as they have competing causes of death. Okay, so this is the main trial that demonstrated once and for all, at least for purposes of U.S. Preventative Services Task Force and Medicare, that screening with low-dose CT scan is actually beneficial in reducing the mortality from lung cancer. And so this was a prospective randomized trial of over 54,000 people from 33 sites across the United States, including the Medical University of South Carolina. And so basically they randomized people to either have a low-dose CT scan annually for 3 years or a chest X-ray annually for 3 years. And they defined patients at high risk based on these criteria: ages 55 to 74, at least a 30-pack year history, so 2 packs a day for 15 years, 1 pack a day for 30 years. A former smoker could be enrolled in the trial if they had quit within the past 15 years, and they had to be medically fit to undergo surgery. And so these are the results. There was a lot of false positives. 1 out of 4 patients who undergo a low-dose CT scan will have a screen-detected nodule. 96% of the time, that is not cancer. But it did meet its endpoint, which was a 20% reduction in lung cancer-specific mortality. Basically, the number needed to screen is 320 to detect 1 lung cancer, and that's very similar to mammography for women over the age of 60. So lung cancer screening works with low-dose CT, but as for any of these trials, are they really generalizable? And the reason I bring this up is it does reflect upon the disparities in the trial. And so if you look at the population of the National Lung Cancer Screening Trial who actually enrolled in the trial, and you compare it to the U.S. Census Survey, and this is a subset, the BRFS survey, which looks at smoking behaviors, and this identified all the people in that survey who would be eligible for lung cancer screening based on the NLST criteria of age and smoking history. And so what you find is that the people in the NLST were typically younger than the people who would actually qualify. There was less minorities versus the U.S. Census Survey who would qualify, and they were more educated. So people in the NLST were younger, not minorities, more likely to be former smokers, and had a higher education than people that actually qualify. So can you really generalize that? And so this kind of falls into what we call the healthy volunteer effect. So if you look at all screening trials, breast, colon, the people that sign up for these trials, they tend to be self-selected. They're better educated, they're more health conscious, they're a little bit worried, they have better access to care, and that's across all screening studies. And so, we asked ourselves, and this kind of comes into the research that we're doing, what about race? Because as I showed you, the population that would actually qualify for screening is more of a minority population. And are we ever going to repeat a randomized controlled trial of that caliber in minorities? The answer is probably not. And so we're kind of left with what to do. And so, as I have already said, blacks have worse morbidity and mortality than whites. And blacks with earlier stage lung cancer are less likely to undergo curative resection. And really, we don't know anything about screening because, lung cancer screening is in its infancy, and this is where the hot research is. But little is known about lung cancer screening in minorities, and unfortunately, we're not going to be able to repeat this trial in minorities or the elderly population or any of those folks that were underrepresented in the NLST. So we're left with what I like to call awesome secondary data analysis. And so we were fortunate enough to obtain the National Lung Screening Trial data and had it published in the Blue Journal or the American Journal of Respiratory Critical Care Medicine. And so really the aim was to analyze the racial differences in outcomes between blacks and whites who participated in the NLST, just to better inform the healthcare community about the benefits of screening in this subset of the population. And so basically we went back through all of the demographics, which were self-reported by the participants at the time of the start of the NLST. And so it characterized subjects by racial background, gender, age, marital status. It looked at comorbidities and education level. And then we went back and reanalyzed, based on race, the lung cancer specific and all-cause mortality. And so the results, and I'm going to take you through quite a few slides, but what we found was that lung cancer mortality was reduced among all racial groups. Didn't matter if you're white or black or Hispanic or other or Asian. If you got screened with low-dose CT, you had a benefit. However, this benefit was much higher in blacks versus whites, with a hazard ratio of 0.61 versus 0.86. That's almost twice, okay? Smoking increased the likelihood of death from lung cancer. So current smokers did worse than former smokers. When you stratify this by race, and that's regardless of age, current smokers are going to do worse than former smokers. So it benefits you to quit, and I will talk to you about that in a minute. But when you stratify this by race, black smokers were twice as likely to die as white smokers in the NLST trial. Okay? So that's something to keep in mind, because you really want to push smoking cessation in all of your patients that come for lung cancer screening, but you might want to come up with some tailored interventions that work more specifically to help the black patient quit smoking. All right, so this is the Kaplan-Meier survival curve for lung cancer mortality by race. And the purple line is the other and missing, but I'll draw your attention to the green line, which is the non-Hispanic whites, and the blue line, which is the non-Hispanic blacks. And so there's a difference there between lung cancer mortality by race in the trial. And then let's look a little bit further. Blacks experienced a higher all-cause mortality than white individuals. So this is looking at all causes of death, almost 30% higher than whites, which really isn't surprising. When I talked to Dr. Getty, who's one of our mentors and does a lot of disparities research, he's like, Nichole, this is true for everything. It's true for diabetes. It's true for hypertension. Blacks just do worse. And so the interesting finding, though, is that in this trial, the blacks who were screened with low-dose CT actually had a reduction in all-cause mortality. So while their all-cause mortality for all comers was worse, if they got screened with a low-dose CT scan, guess what? They did better. And so we hypothesized that perhaps having a low-dose CT improved access to medical care in this population in the NLST. And this is kind of small, but what we have seen, and this is just kind of background to support these notions, is that minorities are less likely to have access to healthcare services. And in 2013, they looked at it, and 18.9% of blacks were uninsured versus 12% of whites. Interestingly, if you delve into the recruiting mechanisms for the NLST, 7 of the sites had targeted strategies for minority participants. And what they found was that these patients were less educated, with lower income, and they were less likely to have insurance. So maybe this subset of minorities that participated in the NLST that were actively recruited now all of a sudden had access to care. And when you look at the actual NLST, a higher proportion of minorities were uninsured, 13% versus 5% of white participants. So that kind of supports the notion that perhaps the reason that the all-cause mortality went down in those screened with low-dose CT is all of a sudden they had access to care. The other thought is that the higher sensitivity of low-dose CT probably picked up other abnormalities, so not just a lung cancer, but you might see a aortic aneurysm that's getting ready to rupture, and you get the person into the right place, or a thyroid nodule, or anything else that you can find. Severe coronary calcifications might have prompted a stress test and a cardiac cath that prevents that guy from dying from a heart attack. So that's kind of what we surmised. And this is the Kaplan-Meier curve that shows pretty dramatically, the blue line being the non-Hispanic blacks versus the green line, and the difference in all-cause mortality by race. But remember, this improves in those blacks that were screened with a low-dose CT scan. So if you look at the demographic comparison between the blacks and whites in the NLST, what we found, not surprisingly, is that the blacks were younger, more likely to be current smokers, and have more comorbidities and fewer years of formal education. And this was all statistically significant. And these are the demographics that I explained to you before are associated with poorer lung cancer survival. The differences aren't surprising, as Dr. Getty says, but there's important implications here for initiating population-based screening in blacks. So I will highlight a survey study that was done back in 2007 by one of my other mentors, Dr. Silvestri. This was a random digit dialing. They just pretty much called people up on the phone and asked them about their preferences for lung cancer screening. And this is obviously before lung cancer screening was ever approved. But what they found is that people who were current smokers, those with low socioeconomic status, those with more comorbidities, were less likely to say, I have a primary care provider. And, you know, historically, primary care providers are the ones that are referring people for screening. If you think about your own health care, you know, the people that tell you to go get your mammogram or your colonoscopy are your primary care providers. And if you're a current smoker, you have lower socioeconomic status, and you don't have insurance, you're less likely to identify a primary care provider, so you're less likely to undergo screening. They also found that these folks had a poorer understanding of the benefits of screening, and they actually said they were less likely to undergo screening for lung cancer. So, you know, really with lung cancer screening, this is the first time we're targeting a habit. We're not targeting somebody because of their gender or their age. We're targeting them because they were tobacco smokers or are current tobacco smokers. So, you know, current tobacco smokers are just less educated and less likely to have primary care. So this is going to be a hard group to reach, I think, as we try to do broad-based screening. So other items to consider are cost. The individual expense for screening may present another access issue. And so there was a great survey study that was done by this person whose name I will not even try to pronounce. But basically, they did a survey of people who were they had primary care providers. They were coming in and they looked specifically at minorities. And they said, okay, so here's your set of questions. How do you feel about lung cancer screening? Well, they were all really enthusiastic about it. But then when you told them there was a cost, there was a significant drop-off to who said, yeah, I'll do it. So if you said, okay, you have to pay $50 out of pocket for your copay, this is what happened. And you can see across the board, whites, blacks, Hispanics, but most dramatically in the Hispanic group, 77 to 15%. Like, first they say, yeah, I'm in, and then they say, you got to pay. They say, oh, no, just kidding. And this was all, theoretical. But, these people had primary care providers. So it's interesting. I think, there's a lot of research questions to be asked and how to reach minority groups to reduce disparities in lung cancer screening. We don't know exactly what the breadth of lung cancer disparities in screening as yet because it's so young, but if you look at other screening tests, mammography, colonoscopy for colon cancer, there's disparities in screening there, so there's no reason to think that it's going to be any different in lung cancer screening. So the last little bit I'll highlight here is some of the policy statements on the implementation of lung cancer screening. So as I mentioned, in 2011, the NLST came out. There are very few early adopters of lung cancer screening because it wasn't reimbursed. 2013, the U.S. Preventative Services Task Force said, yeah, we give you a grade B recommendation. And then it took 2 years for Medicare to say, well, yeah, okay, we'll pay for that for our beneficiaries. And basically, CMS approved lung cancer screening based on this policy statement. They actually went to the American College of Chest Physicians and the American Thoracic Society and said, give us your policy statement. They used this policy statement to defend it to CMS, and none other than our own George Silvestri was there, so it's interesting to hear how it went down. But they came up with, the components needed for a high-quality lung cancer screening program, which we here at MUSC Hollings Cancer Center are now acting upon. So this has to do with who's offered screening, so what criteria. And CMS wants to see that 90% of the time we are offering it to the right people, and the right people is by their definition. So there's a whole talk I could give on lung cancer risk and who qualifies for screening, but there are professional societies, including the NCCN or the National Comprehensive Cancer Network, who recommend screening for folks that don't meet criteria based on additional risk factors such as a primary relative who has lung cancer, et cetera. And you just won't be reimbursed for that. how often and for how long. So you stop screening once the person's medically unfit to undergo surgery or they've been quit for 15 years. How the CT scan is performed, and that has to do with how the radiology department dials in the amount. Remember, this is supposed to be low-dose CT scan. Just on average, a regular CT scan is 32 millisieverts. A low-dose CT scan is around 8. Lung nodule identification, because I told you 1 in 4 patients will have a lung nodule, and that can cause distress. Structured reporting is how we put it out. All of these criteria, lung nodule management algorithms, because unlike a colonoscopy, when you do lung cancer screening, you see a spot and you can do nothing about it. When you're doing a colonoscopy, you see a polyp, you take it off. So, it's just a bunch of shadows. And then smoking cessation, and I'll highlight that in a minute, and patient and provider education, as well as data collection, because we do have to give our data to CMS registry to prove that we are screening the right people. And so, I don't know why I did this again. Sorry, animation bad. Smoking cessation, it was just supposed to highlight yellow, because I'm going to talk about smoking cessation here, because I think it's really important, and we've done some research on that. So really, we just had this published last month in the Blue Journal as well, and so we wanted to know about the association between smoking abstinence or quitting and the mortality in the National Lung Cancer Screening Trial. And the reasons for that are outlined here. So screening should be a teachable moment, right? You've got a captive audience. They're current smokers. They're coming to see if they have cancer. Mr. Smith, you must quit. Is it really a teachable moment? We don't know that, because the only randomized trial within a lung cancer screening venue didn't show that there was any difference in it being a teachable moment, but we would like to think so. We would like to think we can empower our patients and motivate them to quit smoking. And the other reason for that is that smoking cessation is super cheap. If you look at the quality for adjusted life year, it's like $1,100. If you look at the cost of screening folks with low-dose CT scan, it's like $80,000. So if you can get somebody to quit smoking, you are totally getting more bang for your buck. So the primary aim of our trial was to determine when abstinence would match the results of the National Lung Cancer Screening Trial. And so what do I mean by that? So the National Lung Cancer Screening Trial showed a 20% mortality reduction from lung cancer screening. So our question is like, if I never screened you, Mr. Smith, at what point of you quitting will you meet that benefit? Like, where do you get that 20% reduction? That was the endpoint of the trial. And then the secondary aim was really to determine if there were differences in abstinence related to race, and that kind of ties into the whole disparities piece here. So I'll walk you through the results. Not surprisingly, current smokers had increased lung cancer-specific mortality and all-cause mortality compared to former smokers, irrespective of the screening arm. So if you're screened or you're not screened, it doesn't matter if you're a current smoker, you do worse. I've said that already. Smoking is bad. Where's Graham Warren when you need him, right? Okay, so the risk of lung cancer death decreases by about 6% for each additional year of smoking cessation. So if you have somebody in the office, you say every year you quit, you reduce your risk of dying from lung cancer by 6%. Those are things you can say to someone. And if you looked at black former smokers, and this is really interesting, and in our cohort there was only 794, but black former smokers had a more pronounced benefit from smoking abstinence than their white counterparts, like almost twice as much, if you look at that. And okay, yeah, so the confidence interval hits 1, that's probably a size thing, but still, I mean, it's definitely a signal, and I think it's important to consider when you are offering screening to someone and cessation. Blacks do better if they quit smoking. All right, so I'm going to walk you through this because this was the crux of the question we had. Where on the continuum do we actually meet that benefit, that 20% reduction? So we took all former smokers, right, because we want to know at what point when you quit do you do great. And so we stratified them by those that were in the control arm, which is a chest x-ray. So I call this blue arm, I didn't get screened. And then the spiral CT arm. So at what point on this blue arm I didn't get screened does just quitting, because I'm a former smoker, give me that 20% reduction, which would be a hazard ratio of 0.8. And the little red arrow comes up right around here, and that's at 7 years. So that's something tangible that you can say to your patient. I can screen you till the cows come home. And my goal right now is not to say we shouldn't screen, because if you look at this black line in former smokers that did get screened, obviously, they have an even increased benefit to that 20% reduction. In fact, at the 15-year mark of screening a former smoker, the reduction in mortality surpasses that of the results of the NLST and goes from 20% reduction to 38% reduction. So you have an additive benefit to screening a former smoker with LDCT, but simply quitting boosts how well they do. So this is something very tangible that you can say to a patient, right? When you're trying to get them to quit smoking, Mr. Smith, if you quit smoking, you're going to get that benefit. I will screen you till the cows come home, but you can help yourself even more and boost how well this is going to reduce your mortality by simply quitting smoking. And so then this other three-dimensional graph that we have here is the interaction between pack years and quit years. And allow me to walk you through this. It makes intuitive sense. So right here is the hazard ratio for death on the y-axis. On the x-axis is the number of years quit. And on the z-axis here is pack years total. So if you go to this little corner right here, this is the lowest risk person. So they quit 15 years ago. They only have a 30 pack year history. Obviously, their hazard ratio for death from lung cancer is much lower than a guy who might have quit yesterday up here, who smoked 120 pack years and hasn't quit at all. Okay, so you have the highest risk. Basically, what this says is that the more packs you smoke, the higher your risk. The less time you quit, the higher your risk. And it all makes intuitive sense. And so we went ahead and stratified again by whites versus blacks to look at former smokers. And this just is the graphical representation of what I showed you on that first slide. And so what you can see is that former smokers, black former smokers, by quit years, their lung cancer-specific mortality reduces at a faster rate if you calculate the slope, and at a much more beneficial rate than whites. So quitting smoking in the black population is even better than it is in the white population. We should all have everybody quit smoking, but this is just something more to precision medicine when you're having talks. You see who's in front of you, and you can really relate to who they are and how they might benefit. So as I said, that's a typo, sorry, info for educating patients. And this is basically what I said. If you're abstinent for 7 years, you have a 20% mortality reduction. And the combination of low-dose CT scans and screening almost doubles your mortality reduction. And obviously, the more packs smoked and the less years abstinence confers the higher risk for developing lung cancer. And that's that three-dimensional chart that I showed you. And blacks benefited more from abstinence than whites. So additional considerations. And so this kind of gets into the whole background of things. And so black individuals in the NLST were more likely to be current smokers, but they statistically had a significantly lower pack year smoking history. So if you looked at the number of pack years, it was lower. And so this is really alludes to the racial differences in smoking patterns that I brought up earlier. Blacks smoke fewer cigarettes but inhale more deeply and smoke for a longer duration of years. They're more likely to smoke cigarettes with a higher tar level, therefore achieving higher indices of smoke exposure with the potential for greater physical dependence and net toxin exposure. And when you look at black current smokers, they were 4 times more likely to die from lung cancer than black former smokers. So you really want to get these folks to quit. This really highlights the importance of smoking cessation efforts in this group, but it might be difficult to reach this population. And there's been a number of research studies that have been published looking at black smoking patterns. And a couple of them have shown that it's really used as a mechanism to cope for stress. They're in a lower socioeconomic status. They might have a single-family home, et cetera, and so they're more stressed and more likely to smoke. What they have found is that when blacks go to a formal smoking cessation program, they're less successful in quitting than whites. And there was a systematic review of a number of, it was like a Cochrane review of a number of different interventions in black individuals. And really, there's a lot of heterogeneity in all of the interventions that were delivered, but they found that church-based programs may be more effective, but it's not like unequivocally effective. So this is another area now I think that can spawn research questions. We were fortunate enough, depending on how you look at it, to be in the Southeast. We have a lot of higher black population. We can look at trying to tailor interventions for smoking cessation to that population. Here at Hollings with our lung cancer screening program, like I said, my co-director is a smoking cessation expert, so we really believe in the importance of incorporating the two, not only from a cost perspective, but it's also the right thing to do. You have a captive audience, and I think there's a number of research questions that we can ask, not only about incorporating smoking cessation into a lung cancer screening program, but looking at the racial differences and tailoring those types of smoking interventions to the population in front of you. So in conclusion, and I'll tell you about some future studies that we're looking at as well, black individuals benefit greatly from screening from lung cancer using low-dose CT. But to realize the benefit, it's really important and critical that we implement strategies to place extra emphasis on issues of access. If they're more underinsured, how are we going to outreach to these folks and increase the availability of smoking cessations that are effective for minority groups. So we have this two-pronged task to try to figure out how to get this population who might not necessarily have a healthcare home. So other areas of investigation, we talked about, sorry, again with the animation. So the last thing I will say is this patient and provider education. So I haven't really talked too much about the generalizability of the National Lung Screening Trial, except the differences in race and minority representation and age, but there's been a number of studies looking at the risks and the benefits of screening. So gone are the days of saying, Mrs. Smith, you're 50, go get your mammogram. Okay, doctor. So now there's this whole thing called shared decision making. And actually CMS realized, and I think some of the reasons that they hummed and hawed over whether or not they were going to approve lung cancer screening was because of the risks of lung cancer screening. And the risk is not the scan. You lay in the scanner and you go through. It's a 20-second exam. That's not the risk. The risk is what you find, because 1 in 4 will have a nodule. And not surprisingly, in qualitative research that's been done that I don't think I'm presenting right now, when you tell someone they have a nodule, they automatically think they have lung cancer. So if someone goes into the scanner uneducated about the risks and benefits of lung cancer screening and they get a letter that says you have a nodule, they're going to freak out. And that's not the right thing to do. And so in incidentally detected nodules, it's been shown that doctors are not very good at communicating what those risks are and what it means. And so given that, and there's also a risk of overdiagnosis, we can actually detect cancers that are very slowly growing because these scans are so sensitive. And so someone might undergo biopsy surgery for something that never would have killed them. There's also the radiation risk, et cetera. And so Medicare said, we're going to pay for a shared decision-making visit so that you, before you send your patient to the scanner, can have a conversation with the patient and give them the information to make an informed decision that falls in line with their cultural values and beliefs. And so that's some of the research that we're doing right now. So shared decision-making, there's this emphasis on shared decision-making. A few clinicians are trained in methods to promote effective communication with patients, although we think we're awesome at it. None of us were trained in it. For the docs in the room, did anybody ever have ever have a communication class? Probably not. And so we think we're great, but we're not. I mean, well, then there's Ben, because he talks for a living to people. So the competing demands of a practice really limit what can be done in a 15-minute visit. So if you think you're out in the trenches, and I know this because we just went out and met with the primary care providers at MUSC. They said, we're out in the trenches. I've got 2 minutes to talk to you, but I've got a patient who's got really bad diabetes with an A1C of 15%, or 15, and he's getting ready to lose his leg. I don't have time to tell him the risks and benefits of lung cancer screening, nor do I know the nuances of that. And we've actually conducted some focus groups at the VA with primary care providers that really highlight the fact that they don't know, even after an educational session given by yours truly, which means maybe I'm not a good communicator. But anyway, so they don't know what the risks and benefits are of lung cancer screening, nor are they able to communicate that. I had one physician say, the risk is 50-50. You can't just be a little bit pregnant. No, the risk is different depending on how much you've smoked, et cetera. And so it's rarely discussed in typical clinical encounters. And so some really smart folks did this thing called the decision survey because they wanted to see how informed a decision was between patient-provider discussions for cancer screening. And so they surveyed over 1,000 patients over the age of 50 who would presumably qualify for screening services and asked them to think back to their last provider interaction. Now, there's a lot of recall bias associated with this, but basically what they found is, yeah, the majority of people get their information about screening from their primary care provider, right? That's the gatekeeper. But providers don't elicit screening preferences, like only 31% of colorectal and 57% prostate. And not surprisingly, 90% of providers discuss the pros, and very few of us discuss the cons. So we're giving a very biased view about screening, like it's the greatest thing, you should go get it done. But we don't discuss the pros and cons of it as we should be doing. And I think it's really cool that Medicare is saying, we think this is important, you should do it, and we'll pay you for it. Because then when people say we'll pay you for it, they start thinking about it and how to do it properly. So we have an ongoing trial on shared decision-making and lung cancer screening. And so it's a pilot project that was funded through the Hollings Cancer Center that's ongoing. And so we're doing a pre and a post intervention. And basically we're assessing knowledge the patients have of lung cancer screening, the testing, what their beliefs are about it. And then they come in and they see myself or LaShanta. And we take them through a shared decision-making intervention, which is a tool that lists the risks and the benefits. We actually have a paper shared decision-making tool and a computerized version that was developed by the folks in Michigan. And it really just takes them through. And the great thing about the intervention is risk is not the same amongst all. I think hopefully I proved to you that, the more packs of smoking that the more pack years you have, and the longer you've smoked, your risk is much higher than someone who is at the minimum, like 55 with a 30 pack years versus a 75-year-old with 120 pack years. Like, that guy's way at risk. And so what this tool allows us to do is an individual calculation. So I can tell the patient in front of me, in the next 6 years, your risk of developing lung cancer is 7%. And that's high. And so then it has a little demographic that shows how many people, 1,000 people just like you. If I put 1,000 people just like you in an auditorium, 40 of you would die from lung cancer. If we screen you, we'll save 8 of you. 32 will still die from lung cancer. And then it goes through, but 365 of you will have a false positive, and it takes you through everything so they can really understand and see it in a pictogram about the risks and the benefits of screening. And so that's something that's ongoing, and our hope, I think, is to, we're exploring cultural beliefs to try to tailor this intervention so that we can make sure we have culturally appropriate shared decision-making visits for the minorities to see what they understand, et cetera, and try to be sensitive about that. So there's a lot of areas of ongoing research, and I think there's going to be a lot of areas that we can investigate in the future. And so that's where I'll end, and I'll take any questions, but I wanted to say a big thank you to my research colleagues, including the Thoracic Oncology Research Group. That includes Gerard Silvestri, Nick Pastis, Needy, who is my fellow and has done a lot of that abstinence and smoking cessation, Kate Taylor, who is the most amazing research manager, and I'm not saying that because she's just in the room, Lindsay Owens, who is one of our research coordinators, and then, of course, all of the folks at the Charleston VA COIN, with which I would not have been able to do all of the secondary data analysis, including Leonard Aghetti, who's the Disparities Health Services Research Extraordinaire, Mulgetta, who loves missing data, Chinita, who is a great behavioral researchers, and Charlene and Elizabeth Payne, who was the statistician that has now gone on to get her PhD, who did the first couple of trials with us. All right, I've said a lot. Does anybody have any questions about anything? No? All done. Questions, comments? Yes?
Yeah, very nice overview of things. I've got a lot of questions.
All on your phone?
I did. I'm making a list of them.
Okay, hopefully I will answer them for you, Dr. Carpenter.
So one of the things, you've laid out the problem pretty well.
Mm-hmm.
How are we going to change this in South Carolina? I mean, just doing these small little things with patients is great.
Right.
We have these decision guides, but really it's a much bigger issue.
Oh, you're
How do we reach the right people to get the benefits of early detection and smoking cessation? For example, are we offering the incentive of free screening if people quit for 6 months?
No, we are not offering that incentive, and that's one that I think is not an unreasonable one. Have somebody come in, and if you quit for 6 months and your urine cotinine shows that you've quit for 6 months, then we'll give you a free scan. I think, fiscally speaking, we'd have to get that through a lot of people. But I think that's a reasonable research question, and you could randomize that way. And so you're right. Doing these little itty-bitty interventions, I think, is not the way to go. I think that we would need to try to come up with a broad way to implement these things. But it's trying to reach folks that might not necessarily have a primary care provider. So you can talk about radio campaigns, billboard, poster advertisements, going to local churches and getting buy-in. This is really that patient-centered outcomes research that everybody talks about. Especially when you're putting in a grant for Pecoria, that's a lot of fun. But really, I think that trying to do some community-based participatory research where we find novel ways to reach these groups, and then that you don't necessarily need to reinvent the wheel. Chinita's done a lot of great research looking at getting folks to come in for breast cancer counseling and genetic counseling. And so I think that now that we're defining the scope of the problem, trying to look at ways to implement on a broader basis within the state, would be our ultimate goal. We've just kicked off here screening, and so we're starting small and hoping to end up big. Other questions on your list?
Well, I have a couple. You mentioned this a little bit with the spiral CT scanning, because you're imaging somebody's chest, and you're going to find serendipitously some other things.
Oh, yeah.
And are we exploiting those opportunities? Because many times people might not be at risk of lung cancer, but they're going to drop dead of a heart attack, which is probably more likely
Oh, well, yeah, so we don't have to protocol the scanner in any different way. You know, you dial in the amount of radiation you want to give, and it's the reading radiologist here, James Ravenel, who is going to see all of these incidental findings. And, you know, anecdotally, at the VA, we've been screening for 4 years, and there's a number of incidental findings. You know, you don't have to change it or protocol the scan to do anything. You just have to have a radiologist that will read it. And so with this structured reporting, we're talking about calcium score for coronary artery disease, emphysema, thyroid nodules, aortic aneurysms, and all of that gets reported to the primary care provider, who then will act upon it. You know, if somebody's got a high coronary calcium, like there's like an LAD lesion ready to off them, then sure. And I think that that speaks to the reduction in all-cause mortality in the blacks and the NLST that improves. So I think, yes, there's definitely structured reporting, and at the national level, we're coming up with guidelines on way to report those findings such that they don't fall through the cracks. Because there's pretty much radiology recommendations for each of those findings to make sure.
So it relates to the shared decision-making,
Mm-hmm.
because the benefits of screening are likely a lot bigger. And the risks of continuing to use tobacco, by the way, are, you know, it's not, you know, 1 in 4 or whatever. It's 1 in 2. You're sitting there, 1 in 2 people are going to die prematurely if they're smoking cigarettes. That's the audience you've got. You've got people who smoke, but 1 in 2
is going to die from some,
prematurely.
right?
Some percentage, maybe 10%, will have lung cancer.
Yeah, no, and I think that.
Or a variety of other diseases that they're going to die from. So again, trying to reinforce that and building that into the shared decision-making process. Because what I've seen are guys that talk about lung cancer only.
Right.
And, you know, really the screening is broader.
No, and I think that's a great point, for sure. Anything else, Dr. Cummings? No. Bob?
So you mentioned earlier on that there's not enough data, I gather, to examine driver mutations in ethnic groups and ask if the race of the mutation is different.
Right.
But that's kind of changing, right?
Yeah, I think so. I just don't think anybody's looked at it. And I think that's a marvelous question, right? So we've got all of these mutation registries, for lack of a better descriptor. You know, they had the Lung Cancer Consortium project that looked to identify the number of driver mutations. And I don't know that anybody's looked at it from a racial standpoint. And I think that that's a marvelous question because, you know, we just don't know if, one, if blacks are appropriately being tested at stage 4 diagnosis. Like, are we even testing them? I mean, we should. But this institution, yes. Oh, absolutely. Here it is, for sure. But, like, that doesn't we are, like, you know, the ivory tower.
At most places, I mean, of course it is at places like Mass General, Cancer Center, but at most places it's not going through it. And
Well, I mean, I don't even think, I think that even to test anybody with the newly diagnosed stage 4 lung cancer, you know, we say you must, and I lecture at national meetings as a pulmonologist, you must get enough tissue for molecular analysis. It's the most important thing to do for your patients. But whether or not that translates, you know, they don't have the technology. Not everybody has next-gen sequencing. I mean, 2 blocks down at the VA, I'm fighting to get them to use the next-gen sequencer because we don't have one at the VA. They have to outsource to Quest, but they don't have next-gen and blah, blah, blah. You know, and what I'm hearing from pathology is, oh, well, that's just made for academic centers. It's purely academic, and, you know, there's not necessarily a targetable action for everything. I mean, come on. So,
There's so many targeted agents now.
exactly. We're preaching to the choir, Bob. So I think that I think those questions need to be asked of the data that's out there, like what % of blacks or Hispanics have these driver mutations. Because it's interesting, and I think we need to know. And then of those that have the driver mutations, what % are getting targeted therapy? So that's another research question in and of itself.
So I'm going to answer that question. So as you know, there was a remarkable shift in the demographics, I guess, of driver mutations between ethnic groups. So in Asia,
Right.
you have very high frequency of EGFR
Uh-huh.
mutations. And then pop-up mutations that are generally non-smokers.
Right.
And I gather they would not be going to the NLST screening.
Exactly.
But nevertheless, there ought to be data like that. Is there any evidence that says that the frequency of lung cancer
right. Oh, yeah, no, I think that's a great question, too. And that's going to require, big data analysis and looking at a lot of different, groups and having detailed. And so I don't know, yeah, we don't know. But I think that those are great questions, really. And it's an exciting time. Anything else? Yeah, hi, Pat.
So since the Affordable Care Act started, is there a change in the ability to pay for the screening?
Yes, it's actually a covered benefit under the Affordable Care Act. They shouldn't have to, is what we're told and trying to understand. Cassie Frazier is our nurse practitioner for the lung screening program here at Hollings, just to introduce her to everybody. DeShonda in the back is the admin person taking care of everything as well for the lung screening program. But yes, so our understanding is that it's a covered benefit, and hopefully, yeah, exactly. So if you have insurance under the Affordable Care Act, and presumably if the Affordable Care Act does what it does and insures more people, we should be able to advertise for preventative services that people won't have to pay for. Other questions? All right, thank you so much for your attention. Have a good day, everyone.